Baum from Bad Berg in Germany, and Richard has an extensive experience in PET, and he's going to share this with us now. Thank you.
Thank you, Robert. I will not provide you images from Cambodia, so I have been there in March this year, and I can understand your feeling about this. It's really wonderful. So I will speak about neuroendocrine tumors and actually PET-CT, because PET is an old modality and PET-CT will be the future use of in oncology. I'm coming from Bad Berka, which is a small city just in the middle between Frankfurt and Berlin. And we have there a large neuroendocrine tumor center, which you can see here is beautifully located within the Thuringia forest. And we see about 1,000 neuroendocrine tumor patients per year. And I'm very happy to collaborate with my colleagues from internal medicine, abdominal and endocrine surgery, interventional radiology, and our specialty. And here is our ward, and we have 22 beds for treatment of patients. So we are doing about 400 radiopeptide therapies. Before I start, I would like to mention that the basic principle and groundbreaking idea comes really from this man, who is Paul Ehrlich, who won the Nobel Prize for Medicine in 1908. And he created the so-called Seitenkette theory or side chain theory. And these are hand drawings by Paul Ehrlich. And he was the first to name receptors and what we call today receptors and side chains. And that came from his idea as a pathologist. When he was staining tissues with colors, he saw that specific colors were binding to specific tissues. You all might know hematoxylin eosin staining, and this was developed, for example, by Paul Ehrlich. And he later on created this concept of magic bullets, or how he say Wunderkugeln. That means that you have a specific substance which binds to a specific receptor or a ligand binding to its receptor. Our modern side chains look like this. We have a target, and that can be an antigen, or it can be a G-protein coupled receptor, like a somatostatin receptor, or it can be transporters. Then we have a ligand binding to this, addressing the molecular address. That can be antibodies or peptides or substances like your sandostatin you inject. And then for nuclear medicine, of course, we need a reporting unit. And this is bound via a linker and a chelator. A chelator is a cage which tags, the gallium, for example, which we use for imaging, or technetium or indium. Or you can also have therapeutic radionuclides like Y90 or lutetium-177, which then bind to these chelators. Very shortly, I would like to explain for those people who are not familiar with PET, what is PET. Actually, positron emitters are atoms which have too much positive load in the nucleus, and this is emitted by a positron which has the same energy like an electron, and both combine together. And then you know all the famous Einstein formula. The mass is actually converted into pure energy, which is gamma emitters, and this can be detected by this PET machine, which consists actually of about 20 to 30,000 small crystals, and they register the gamma emission, and then this gamma emission is used to provide an image either of a region, like in this case, a metastasis to the brain, or you can also image the whole body. Now, the advantage of PET-CT is that it combines two modalities, a very good one for resolution, showing very small things like CT and MRI, as you just heard. So the resolution is less than 1 millimeter. And PET, which is a very highly sensitive method with a sensitivity in the picomolar range, which is about 10 to the 8 or some 100 millions more sensitive than CT and MRI. And what we are using is the so-called molecular resolution, which is in the range actually of nanometers. So if you combine PET and CT, you can combine metabolism and anatomy, and this just increases your diagnostic quality. To illustrate this, I would like to show you an example from a children's book. I don't know who knows this children's book from Richard Scarry, but the task is that there is a small person, which is called Lowy, and it said it looks out of a window. And now the child should find Lowy. Now there are many, many windows, as you can see here, in houses and cars and so on. And CT is like this. It very nicely shows you all the organs, the structures, the houses, the windows, just in black and white, not in color. So you got colorized now also, I see. But it's very difficult to say where Lowy is, if it's in the drug, Apple Mobile, and police station, and so on. And that's what is PET is. It just shows you the Lowy, but you don't have the environment. You don't know where he's really looking out. And PET-CT is like this. You have the structure, and you also have the single lesion, so to say, which you can pinpoint by PET. So the advantages of PET and CT is, as I said, it combines morphology and function. And another very important thing, we have quantitative data. MRI and CT and ultrasound is mostly looking at images, very high resolution images. PET is also a quantitative method, so we can give some information on the amount of receptors, for example. And one example I show here is a coronal slice of a PET scan, and if you focus on this lesion without the CT scan, it's very difficult to define where it is, because the transversal section of this shows there is no surrounding activity. You see only Lowy, but you don't see where Lowy is. And with a CT scan, you can really pinpoint this lesion and say it's, for example, in this case, a lymph node metastasis. So the sensitivity, of course, is much higher than for ocular scan. And to illustrate this, this is a whole body ocular scan 24 hours after injection. This is a bone scan which shows some lesions, and in comparison, you see the PET scan shows you many, many more lesions, especially in the bones. We use different compounds, different somatostatin analogs. I do not want to go into detail due to time reasons, though there are DOTA-TOC, DOTA-TAE, DOTA-NOC, DOTA-BOMB, and many others. Just remember that all these are peptides targeting the somatostatin receptors, and you need not to worry, all work in a clinical environment. The radioisotope we use nowadays is gallium-68, which comes from a radionuclide generator, so you don't need a big, radiochemistry and cyclotron unit, which costs you hundreds of thousands or even millions of dollars or euros. You just need this generator, which can be established in any department, even in Ontario, I think, without too much cost. And it's convenient, fast, in-house preparation. And gallium chemistry is well studied. It's nearly in nuclear medicine now 40 years, and we see a rapid increase of PET centers without cyclotron. For example, in Europe there are more than 60 institutions now using gallium-68, and as far as India, Delhi for example, or South America and Chile, they are using now gallium-68. And of course the same product can be labeled with lutetium or yttrium for therapy. That is like the generator looks like when we started in 2004, and with a close collaboration to Professor Röstrup in Mainz, who is a radiochemist developing the system. And we have now a fully automatic synthesizer available, which is GMP concordant and can be used in any department which has a PET. What is more interesting for you probably are the clinical indications, and I would like to start with staging of neuroendocrine tumors for whole body diagnosis. And one of the big advantages of PET-CT is that it is a one-stop shop method. You can detect the primary, as I will show you, metastases and so on, in one single procedure, which takes 15 to 20 minutes, and then it's finished. Detection of unknown primary tumors. About 30% of neuroendocrine tumor patients present with an unknown primary tumor. PET-CT is very sensitive, I will show you, and evaluation of receptor status before therapy, which is very important. This is one example of a patient with a primary tumor which was previously not recognized as this in the ileum in this case. And you see lighting up the primary tumor, you see small lymph node metastases, and you see bone, in this case bone marrow metastases. You can even differentiate between bone and bone marrow metastases. And this in one whole body view. This is another example of a non-functional neuroendocrine tumor patient which came very late with multiple liver metastases, as you can see on the CT scan and on the PET-CT. The question is, where is the primary tumor? Now, this patient had been seen by 3 different institutions before. I think he had at least 4 or 6 CT and MRI scans. And the primary tumor was not described, not by ultrasound and endoscopy. But we were able to localize it in the tail of the pancreas, a very typical localization for an unknown primary tumor. And you see there is no change of morphology. CT scan still looks normal in this region. And you have this focal uptake, which tells you that the primary tumor is there, which was then confirmed by endoscopic ultrasound and biopsy. Another very important is restaging of patients, follow-up, especially in cases where you have rising tumor markers, you all know, like chromogranin, or specific markers like calcitonin, glucagon, and so on. And I would like to show you one case. This is a planar octreous scan image of a patient with a rising chromogranin A level after resection of a liver metastasis. So this is a completely normal scan, but the PET-CT in this case showed a single liver metastasis, and what was very interesting, also a metastasis to the stomach, which you can see here, which is lighting up and also was confirmed by endoscopy and biopsy. So why was this lesion not seen on the octreous scan? The reason is very simple. If you look here, the kidney is just in front of the lesion, and the planar scan did not detect it because it was hidden behind the kidney. Another case, a very interesting one, of a patient with a neuroendocrine pancreatic tumor producing calcitonin, and she had been operated. The primary was removed, also the left liver lobe and the spleen had been removed after the primary procedure. And then she presented with a rising calcitonin, and calcitonin is a very specific tumor marker, so you can be 100% sure there is tumor. Now she had overall 8 different CT, MRI, and so scans, and nobody was able to see it. But when we did the PET-CT, there was one lesion in the so-called S1 segment of the liver, and before resection of this lesion, we did what we call a three-modality fusion. You can even fuse these images, the PET and the CT, to an MRI and get the vascular component, which is very important for the surgeon before operation. And the surgeon was able to remove it, and it was a 1.5 centimeter lesion. And the follow-up 2 years later showed there is complete remission of the disease. Fortunately for the patient, the only thing you see is a clip here. Other examples showing the superiority of PET-CT as compared to conventional imaging. For example, in this case, a normal CT scan, but a liver metastasis seen on the PET-CT. Lymph node metastases. This is one of the most important indications. Some call PET-CT a lymph node machine for detection of lymph node metastases, because we can see small lymph node involvement, less than 8 millimeters sometimes, whereas in CT scan, as you know, it's a size criteria. Only lymph nodes more than 1 or 12 millimeter in size are considered to be tumor involved. And finally, bone metastasis, another big advantage of PET-CT. As you can see here in this example of an osteoblastic metastasis, of course you can see that on the CT scan as well, but you see it better on the PET-CT. But in this case, there is no change at all on the CT scan. But still there is a small lesion, about 3 millimeter in size, which was located in the bone marrow, as shown by a follow-up MRI scan. And some very rare indications, at least thought to be rare. For example, myocardial metastasis in the heart, we found metastases in a number of patients, and we have now a series of 30 patients having myocardial or pericardial metastases, and all of these lesions were thought on octreoscan to be lung lesions. Because you don't see the heart on the octreoscan, you think in the thorax it's in the lung, but in fact it is in the myocardium. And some of these patients we have treated with peptide radionuclide therapy, and as you can see here in this case, in the septum of the heart, after one single cycle of peptide receptor radiotherapy, it disappeared. A very important indication, therefore, is to determine the receptor density before radionuclide therapy. And for that we use something which you might know as sports utility vehicle, SUV, but actually it's named standardized uptake value, okay, which tell you just how much of your agent you inject in a patient is going to the tumor. And the highest uptake or SUV we found was in a patient who is a pilot. You know, he was really managing a 747, and I said your value of 152 matches your high of flight. So it was usually on FDG PET, just to give you a comparison, you see values of 3, 5, 8, or 10. With these receptor targeting agents, we see very high SUV, and therefore we can detect very small metastases as these retrogrural lymph nodes. There are big differences from patient to patient. You know, everybody is speaking about a positive octreoscan. That means nothing. When you look at the uptake, it varies from 3 to 150. So positivity is a wide range. And when you are dealing with therapy, when you are treating patients with radionuclides, you really want to know exactly what is the uptake and how much you should use. Also, evaluation of therapy response is a very important thing to discuss. We would need 1 hour really to discuss it in depth. But just to mention this so-called RECIST or WHO criteria, they look only at size, at 1 or 2 dimensions only, and these are the definitions, but none of these address tumor response with biological or metabolic markers. And just to show you one example of a patient here with liver metastases, large liver metastases, of course you can measure very accurately the diameters. But if you look, about 50% of this lesion is necrotic. You know, it's this dark area containing water, and this is not addressed, not in this case as well, and not in this case. Though which or who, as a radiologist, really looks at all these lesions and measures necrotic masses or not. With PET-CT, this is much easier. This is a patient with 2 liver metastases. After the second course of radiopeptide therapy, they disappeared completely, and the patient remained free of disease for 1 year. And then at another location, metastases were coming up. And as you can see here, we can measure SUV before and under therapy. And it's the same in this patient with a widely metastatic disease involving the thorax, the heart, the liver, and so on. And after 4 cycles of therapy, the patient is now in complete remission. So molecular response precedes morphology. Before something has to change the size, we have molecular or biochemical changes, which is shown by this case with a presacral lesion of a paraganglioma, actually. And if you look at the CT scan, there is not much change in the anatomic image, but if you look again at the molecular response, you see a dramatic decrease of the SUV corresponding to response. Again, I have no time to go into detail, but you can go on with so-called molecular tumor index, or MTI, which is combining the anatomy again and the uptake on the PET scan. So my plaidoyer is desist using only RECIST and use molecular and anatomic response measurements. Of course, we cannot image only carcinoid tumors. We can image any tumor having somatostatin receptors. It's a large list for those who are interested. I have brought a publication with me. There are also more publications with colored images on the table here you can take after it. but just showing you the power of this PET-CT method, which can even localize exactly lesions within the spinal cord, something which is only possible otherwise by targeted MRI. At the end, I would like to speak shortly about other molecular imaging probes for imaging neuroendocrine tumors using PET. FDG, of course, can be used in more rapidly progressing tumors with a high Ki67. You should not say Chi, because Ki comes from Kiel, which is a German city in the north of Germany, and the pathologist was living in Kiel, and he named it Ki67. Otherwise, we can also use F18 fluorodopa, and I have to mention, of course, the pioneering work of Uppsala. Dr. Oeberg is here, and he has used PET already 15 years ago, using very specific tracers for showing the metabolism of neuroendocrine tumors. And again, for those who are interested, I refer to our article in the Seminars of Nuclear Medicine just about 2 years ago. FDG PET is showing you, as you can see here, the rapidly progressive tumors with a high SUV in this case, corresponding to a low uptake on the gallium PET. We call this a flip-flop phenomenon when you have a higher metabolic activity as compared to the receptor density. And F-DOPAR and C11-HTTP, I think the only really indication is the serotonin-positive gap tumors for DOPA, and also medullary thyroid cancers, which can be nicely detected using DOPA, and finally insulinomas. And there is one example I brought with me, is the same patient imaged with 3 different radio tracers. On the left, you see the FDG PET, and in the middle, you can see here the DOPA scan, and on the right, you see in this case a gallium-68 odotate scan. So you can really image in the same patient different properties of the tumor. And one example from Abbas Alawi from Philadelphia, who has imaged children with a disease which is called congenital hyperinsulinism, and it can occur in a localized form. So these kids are born with this adenoma, so to say, if it is localized in the pancreas, or in a diffuse form. Now, if it is localized, the surgeon can come in and resect it. If it is diffuse, it cannot be resected, or it must be a total pancreatectomy. So DOPA PET is able to differentiate between these two entities. So in conclusion, I think receptor PET-CT using this gallium-labeled somatostatin analogs enables molecular imaging of neuroendocrine tumors and their metastases with a very high diagnostic sensitivity and specificity. We have performed in our center now nearly 3,000 gallium-68 PET-CT studies as of September 1st over the last 4 years. The advantages, it's a semi-quantitative, reproducible method, which is a fast protocol. I mean, this is finished within 16 minutes for the patient, right? Comes in, gets the injection, 60 minutes later, the scan is done, which lasts 20 minutes, and then it's finished. And you have everything. You have your CT scan and the somatostatin receptor data. It's the daily use which is possible. Nothing needs to be ordered from outside, and it's less expensive than Octoscan. I think it's a new gold standard for in vitro somatostatin receptor imaging, and there are a lot of new future perspectives. I would like to thank my team, especially the radiochemists here, who helped us a lot to establish this method. And I would like to finish with Henry Ford, who said, anyone who stops learning is old, whether at 20 or 80. Anyone who keeps learning stays young, and the greatest thing in life is to keep your mind young. I hope I helped a little bit to keep your mind young. Thank you very much.